Good afternoon, everyone. I would like to welcome you to the clinical forum, What's New in Perioperative Brain Health, from Prehabilitation to Biomarkers. So we just have 60 minutes. We're trying to have enough time at the end for Q&A. And we have three speakers. There's Dr. Edwards, myself, and Dr. Humedan, who will be presenting. So we're trying to, as I said, keep some time for Q&A at the end. So if you can keep your questions for then, that would be great. And we will not introduce ourselves, just to save some time. So thank you, and Dr. Edwards.
Thank you all so much for being here. We are going to try and make this cozy and fun since we're in a smaller room. I'm going to give you just a quick overview. We're going to try and cover a little bit about brain health, frailty, and prehabilitation all together. I'm going to try and cover a good bit about the latter, just to make it easy. A couple of disclaimers. I really don't have much in the way of financial disclosures, but I have been part of the Center for Perioperative Medicine for the last couple of years and very engaged in preoperative optimization for the last decade and a half. So I've made quite a career out of this, and so that sort of helps frame what I'm going to talk to you about today. A couple things we're going to cover in hopefully just less than 15 minutes, not 20. A little bit about preoperative frailty, how to recognize it when you see it, what tools that can be used, and then how to mitigate the risks that are associated with frailty syndrome. I'm going to try and steer away from cognitive frailty because that's covered with my two colleagues that'll be next, and then what we can do in terms of a multidisciplinary group to help mitigate that risk. So, like you may have heard yesterday during the opening ceremonies, every patient's journey begins with a story, and it's their personal story. So we try and begin these clinical cases with a case, but this is really about this patient's story. And she's coming to us with a history of recently diagnosed colon cancer for right hemicolectomy, history of hypertension, diabetes, COPD, and has recently noticed a change in both her weight, her appetite, her level of fatigue. She confesses that her husband recently died and she's been living alone, family's out of town. So when you see this person either the day of surgery or in your pre-op clinic, or perhaps she's discussed with your colleagues, hopefully she raises some red flags, because this is someone who would also be concerned about her level of independence after her surgery. And I bring this forth because this gets to this forum's framework of looking at what patients are interested in and what their concerns are at this juncture of their life. This forum's framework I want you to keep in mind while we're talking today. That's thinking about what matters to patients, their mobility, their functional status, and medication and mentation altogether. And so as I mentioned, this patient's getting ready to undergo this new journey, and in today's framework with care of the aging patient, we're looking at a different landscape. Our patients are rapidly increasing in age. More patients are coming, more older patients are coming for surgery, and so we're expected to kind of evaluate these patients and come up with ways to perhaps intervene and make things better before surgery, or certainly maybe during the operating procedure, so that their outcome is much better than what they may have anticipated. This gets into looking at geriatric syndromes and lots of complications that are encountered with this patient population. And what are we talking about? A little bit on frailty, a lot on delirium, and perhaps trying to mitigate risks from falls and functional decline. And these are the concerns that most are coming with. So we're expected to rapidly assess, perhaps educate our patients on the risks, look at risks and benefits, and then find a way to mitigate that risk, all in the short course of perhaps a week, 2 weeks if we're lucky, or even having these conversations with our patients the day of surgery. And we've been fortunate that there are a lot of guidelines that have been put out in the last couple of years. Guidelines, practice advisories, and new initiatives. And many of you may remember the American College of Surgeons that put forth the Geriatric Surgery Verification Program. It started in 2012, evolved a little bit in 2016, and then even further in 2019, with these really 6 pillars focusing on patients' healthcare goals, making sure that we're providing goal-concordant care, looking at frailty screening, cognitive screening, anything we can do to intervene to improve malnutrition, mobility, maintaining functional status, and then looking also at social vulnerability. These pillars are also pivotal to what was the next initiative. Many of you have probably heard about this age-friendly health measure that's come forth from CMS that went live in January of 2025. This was a quality program that also adopted a lot of the elements that were from the ACS Geriatric Surgery Verification Program, focused on what matters most to patients, eliciting the patient healthcare goals, individuals, looking at ways to mitigate frailty, assess for cognition, and then looking at their social status, whether or not they're experiencing some vulnerability in their social networks at home. Most importantly, with this and with the geriatric surgery verification program from the ACS, you may notice there's two pieces that are important: a designated age-friendly leadership, and this is a unique opportunity for anesthesiologists to get involved in this space further upstream to actually have a tremendous impact. So this was part of this new initiative, and hospitals can opt in or opt out of this, but if they choose to opt out, they risk actually limiting their Medicare payment reimbursement. And in addition, patients can actually see how hospitals compare with each other on this Care Compare website. So while this new initiative was sort of this mandate, if you're participating in sort of CMS reimbursement, and most of us are, there was an option to opt out. You have the option to, but it's actually publicly reportable. So we had the guidelines, practice advisories, and we also have new initiatives. One of the ones that also came out that mentioned frailty and specifically was the American College of Surgeons, the AHA-ACC, new guidelines for care of the cardiac patient undergoing non-cardiac surgery that was published this time last year. In addition, we also had the ASA's practice advisory on care of the older patient going for inpatient surgery. Both of these practice advisories and guidelines mentioned frailty in particular. The ACCHA guidelines that came out in September of last year focused on functional capacity first, looking specifically at objective measures of functional capacity. And with this, they also dovetailed this in and brought in frailty. So they recommended that all patients over the age of 65 who are undergoing inpatient surgery be assessed for frailty using a validated tool, and they were pretty specific about that, because what we know about frailty is that an early identification does increase patients' odds of being discharged to someplace other than home, which is not necessarily what most patients are expecting. And 50% of these patients who are either pre-frail or suffering from frailty syndrome have an increased risk of losing some form of independence after surgery. We know that frailty is prevalent, it's subtle, so the encouragement here was to think about what objective measures, what validated tools can be used with a strong recommendation. They also provided a nice table, just a quick summary. There are over 90 tools that are available for assessing frailty. These weren't necessarily recommended, but they were just given as examples. But the formal diagnosis of frailty was the pivotal point here, just in making sure that you were encouraged to use some type of validated tool to participate in shared decision-making with patients. In addition, there was a subtle note within this section that there's evidence that does suggest that prehabilitation may be associated with improved outcomes. So identifying frailty earlier, deciding if there's opportunities for intervention and which domains of frailty might be an opportunity for intervention was highlighted in this recent guideline. The practice advisory did the same thing, though while they focused on all three pillars of our perioperative care, pre-op, intra-op, and post-op, they focused specifically on the preoperative screening for frailty, cognition, nutrition status, and psychologic screening, and that's what we'll focus our time on. So when we talk about frailty, we got to start with a basic definition. And this is something that's easy to keep in mind. It is a multidimensional, complex state of vulnerability. It is age-related, not necessarily directly age-associated. So you can have someone that is very young that is pre-frail or approaching frailty syndrome. It is a critical risk factor, however, for older adults. And while it's distinct from age, it is strongly associated with conditions that have progressed over time and is definitely associated with poor outcomes, increased hospital length of stay, readmissions, and like I mentioned, and I will continue to mention, discharge to someplace other than home. Because it is subtle, it is important to use objective, validated tools to recognize. And when you do so, it's easy to put these in sort of buckets because there are various frameworks, various models to think about when you're looking at these different risk assessment tools. I mentioned that frailty is associated with poor outcomes. I mean, we've sort of known this. We've talked about this a lot. Probably one of the most important pieces is this loss of independence that most of our patients will experience if they're coming for a major surgery with perhaps a pre-frail syndrome status. There was a nice study that came out in JAMA Surgery in 2022 that looked specifically at 30-day and 1-year mortality for patients coming that are pre-frail, frail, that it may have some probable dementia. And what they found was even in some of these high-risk surgeries, major abdominal surgery, major vascular, patients who were subtly pre-frail had an increased risk of mortality. Those who were frail had a 30% chance of mortality. And those who also had probable dementia associated with this had an increased 32% risk of mortality. So again, important to recognize early. There are 3 working frameworks to consider in looking at these frailty tools, different conceptual models. The physical frailty phenotype is the first one, and that's pretty basic. That's one we all hear about. That's looking at weight loss, weakness, slow walking speed. Oftentimes you're using some type of grip strength to look at this, and this is sort of this energy depletion model. A second one looks at an accumulation of deficits over time. So it's associated with comorbid conditions, but really puts this into a network of diverse age-associated deficits and sort of puts this all together. The third framework compiles all these in sort of this biopsychosocial model, bringing into the conversations social vulnerability, perhaps some psychological deterioration that are not just necessarily cognitive, perhaps also associated with social isolation. So there are multiple ways to look at frailty, multiple things to consider. It can be quite confusing. So how do we pick one of these tools and use? There are basically some pretty straightforward things to think about. There's a handful of tools that are commonly used and commonly referenced in the literature. And if we keep this into perspective, keeping in mind what you have available at your disposal at your institution, the frailty phenotype or the frail scale are 2 that are almost the same. They're looking at these objective physical measures. The frailty index, the RI, often used for surgical research, and the clinical frail scale are approximating this accumulating deficits model. So this provides a nice example and pretty straightforward, quick, easy reference for you to take a look at if you're considering which frailty tool to use. I mentioned the frailty index. This is sort of this, the nice thing about this, you'll see also people use the Edmonton Frailty Scale. It provides specific questions related to certain domains that can be impactful if you're looking at a prehabilitation program. The frail scale is pretty straightforward, usually requires grip strength, and again, the clinical frailty scale, which is a nice option. A lot of our literature focuses on the clinical frailty scale because this can be done easily, simply over the phone, once you've gone through a past medical history, looked at conditions, medication list, and functional status. Most people can speculate where patients will fall within these 9 clinical scenarios. So in terms of looking at different frailty models, it's always this question, which tool is best? And when you look at the literature, oftentimes the clinical frailty scale sticks out, not necessarily because it's the best, it is highly sensitive and specific and easy to use, but because oftentimes it's the fastest. So most times you'll find most programs, most clinicians, most researchers are using the clinical frailty scale because of all the other elements they're looking for. And so there have been a couple pieces of literature that have come out that have looked at this specifically, which one's best. There's a nice publication both from 2022 and 2020 that looked at all together in comparison, and there's a QR code if you want to take a look at that. I do have a lot of QR codes for references to make it easier. In addition, the ASA put forth this frailty toolkit, which gives you a nice summary if you really want to do a granular deep dive into each one to figure out which one works best for you. But in short, it takes a multi-component validated tool to recognize frailty, and the best choice really depends on your environment and what you have in terms of your plans for prehabilitation. So once you've figured out frailty, patients suffering from pre-frailties or frailty syndrome, what now? So what do you do next? And that's always the question. It's nice to identify this, but what are some practical applications? What can we look at, and is prehabilitation possible? Well, if you think about it, prehabilitation, what that actually means is that it's actively preparing patients for surgery through a form of either exercise, nutritional enhancement, psychological support, perhaps some cognitive training, or all 3 of these components together, and also looking at their social framework. There's sort of a primary and a secondary goal. Obviously, the primary goal is the patient's physical status and physical function. The secondary is to mitigate the risk of readmissions and decrease healthcare costs. So all of that comes together in the framework of thinking about prehabilitation, what that can mean. There's a lot of heterogeneity in the literature, though. So like I just showed you the different types of tools that are commonly used in literature equally. This presents a challenge when trying to get an answer to this question. Because if we turn to literature, you're looking at there's tremendous variability with regards to surgery type, the timing of some of these interventions, the type of interventions, how to initiate, when to initiate, and whether or not it needs to be directly observed or it can be done remotely. So there's a lot of variation. The same question is, can't we just get away with a unimodal program, something simple? Isn't physical exercise just enough? Or do we have to have something that's multimodal? The answer, to keep it simple, is it has to be multimodal. As complex as frailty is, it makes sense that most of this has to be in a multimodal framework. Some of the literature does, however, point to some benefits to just exercise. So if we have to keep it simple, there's literature to support it. This is one piece that came out in 2024. This is a meta-analysis of 10 randomized control trials that looked at multimodal prehabilitation programs in patients undergoing major upper abdominal surgery. And the common theme across the board was that exercise was pivotal and probably the most predominant modality that contributed the most consistent benefits for all of these studies. And so in general, while there's still some gray zone about prehabilitation, exercise in this particular study was the most consistent across the board to be involved in all programs. And we're trying to build resilience if you think about what we're trying to do. So whether it's exercise, nutrition, cognitive exercises, I will leave to my colleagues. We'll talk about cognition in a little bit. It's important to think about also depression screening. And these are it's oftentimes whether or not you're having access to a PHQ-2 or PHQ-9, and whether or not there's an opportunity for some stress reduction, some cognitive behavioral therapy training or relaxation training. Either way, it's multimodal is probably the best approach. While it sounds complex, it is probably the best way to have a patient-centric prehabilitation program in place that is surgery-specific, that is, while it may seem resource-intensive, it depends upon where the patient is in their current status. And so the research is still ongoing. There's a lot that I can share with you. A couple of studies that are currently that are ongoing. I'll share a little bit about prehab and the Prepare trials, there's still a little bit left to figure out about whether or not we need direct observation or we can be working remotely with some of the population. Highlights of some literature, if you want to take a picture of the screen, this is a good one too. There's most of the literature that's come out since 2022 has been impactful in doing a deep dive into the details. But almost each one will point towards some multimodal element. The Prehab trial was published just a couple years ago, and again looked at this specifically. So for our patient in particular, the Prehab trial looked at elective colorectal cancer patients, put them through a 4-week high-intensity supervised exercise training program with nutritional supplementation, focused on protein supplementation, improving mental health status, and also looking at smoking cessation. What they found that this 30 days post-procedure that had tremendous impact on a reduction in severe complications. So this was pivotal. Specifically, they looked at all complications, severe complications, medical complications, and surgical complications, but across the board, this prehabilitation training, this 4-week program, had a tremendous impact. These are patients that had non-metastasized colorectal cancer and were coming for a relatively elective procedure, so had a 2 to 3 week window where they could pause. So again, keep the Prehab trial in mind as we're waiting for the results of the Prepare trial. The Prepare trial initially started randomizing patients in 2020, took a brief pause, and now is back enrolling again. But the aim of this one is to evaluate the efficacy of a home-based multimodal prehab program. And notice they looked at patients that were over the age of 60 who were diagnosed with frailty only by the clinical frail scale. So these were patients that hit the CFS, those basic scenarios over a CFS of greater than 4. They're enrolling over 750 patients, both randomized. And it's a nice, they're doing this in a very succinct way. Interestingly enough, if you look at the screening tools they're using, the Canadian Nutrition Screening Tool, the Clinical Frail Scale, the Functional Status, the DASI screening tool, a 5-time sit-to-stand. So very simple screening tools that you can implement anywhere. It does not take much time. And once they finished enrolling, we'll hear more from this group. While we were waiting, the same group decided to put out just a quick teaser and did a quick little review of the literature, looked at whether or not over 160 unique randomized control trials, looked at whether or not multi-component interventions that were designed to impact and decrease length of stay and improve health-related quality of life had an impact. And they said that, well, because efficacy is a little challenging, these were all different studies, they had different end results. We need essentially a well-powered, multi-center randomized control trial, which is exactly what their study is looking at. So this is the most recent publication that came out this past year. So we're still waiting on the end results of Prepare, but we'll get there. While we're waiting, the general thought is that it's depending upon the time you have, whether it's 1 week, whether it's 4 weeks, whether it's 8 weeks, there's an ideal time to improve functional status. And improving functional status and implementing some type of exercise training program is absolutely beneficial in your populations. So we'll talk about nutritional prehab for just a minute. What we know about nutritional assessments is that it's a critical independent risk factor for postoperative poor outcomes. That malnutrition is is among one of the few modifiable risk factors that has an opportunity for a quick, impactful prehabilitation program. So malnutrition increases risk of delirium, length of stay, and readmissions. In addition, it's easy to screen for. There's a handful of tools that are easy to do, not just about weight loss, not just about albumin levels or prealbumin levels, also looking at a few others. So, and it also can be easily embedded into your healthcare record. This is something that we created for my health system, embedding both cognitive screening as well as nutrition screening, as well as frailty screening in a quick little flow sheet that our nurses can do. So it's easy to put these screening tools into your electronic health record so you can decide whether or not it's appropriate to intervene. Most of your nutritional interventions will look at perhaps immunomodulation as well as protein supplementation. Somewhere between a week or two of a quick nutritional supplementation is almost enough to get them to bounce back, depending upon where they start. So next, a little piece on the psychosocial piece. So we talk about social vulnerability, social isolation in this population, which predisposes them for readmission. It's important to screen for anxiety and depression, and this is part of most nursing screens. This required to do a PHQ-2, and most hospitals have to do some type of depression screening. The PHQ-9 does a little bit deeper dive, but asking your patients about depressive symptoms is important because this is a precursor to delirium. Social vulnerability, we've talked about that a little bit. You guys are probably also well familiar with the requirement to look at social determinants and social drivers of health. Tremendous impact on postoperative outcomes. Psychological preparation is a critical piece of this because this gets straight to whether or not patients can actually make their own decisions, where they're making their appropriate decisions, and also can be done, but we can also have the opportunity to look at psychological preparation for perhaps cognitive behavioral therapies, some imagery, and a lot of opportunities to connect with your patients for shared decision making. So this last piece that I want to emphasize before we finish my time today is that we have to remember what matters most to our patients. This patient's journey, she's worried about the loss of independence. We can do a lot, we can intervene, we actually have time. And so for her, the conversation that's important around her story, around what's important to her, really matters. And it's an opportunity to talk about risk, benefits, and alternatives while we're waiting for surgery. So remember this 4M's framework as you're talking to your patients and you're recognizing who is frail and not. Remember that frailty is multidimensional. Evidence does support that a multimodal prehabilitation program is beneficial, but we're truly waiting for this, the last bit of evidence to support what to do and when to start. And these will be pivotal with large, high-quality trials that are coming. Thank you all for your time, and I'm going to move on to the next speaker.
So thank you, Dr. Edwards, for the overview on how to recognize and assess frailty. I shift a little bit now, and we'll start off with sharing definition of what we mean with perioperative neurocognitive disorders. Then I will explore the emerging field of biomarkers and go over some practical strategies how to reduce the risk of brain-related complications. A little bit about my background. I serve as the program director at Brigham Women's Hospital, and I'm intensivist by training. So my interest in perioperative neurocognitive disorders has grown out of both my clinical experiences and then my work as an educator. So as Dr. Edward mentioned, I like to highlight this New York Times article from a few years back. It brings attention to the important fact that many of older patients, even now, and their families often don't realize what outcomes to expect, even from minor surgery. And so as a result, they are frequently caught off guard. Here's again our patient. As we know, she's been slowing down and is worried about staying independent. And so, as Dr. Edwards pointed out, we need to really think about what do we know about her brain health when we see her in the pre-op setting. I'm starting off with sharing the nomenclature that we're using. So perioperative neurocognitive disorder is used as an overarching term. And there are actually 4 subcategories, and depending on the timing and presentation of abnormalities. We refer to mild or major pre-existing neurocognitive disorders when a cognitive impairment is diagnosed before the surgery. Postoperative delirium refers to an acute event right around the time of the surgery. And then delayed neurocognitive recovery indicates a cognitive decline that is diagnosed up to 30 days after the procedure. And then mild or major postoperative neurocognitive disorders refer to cognitive decline diagnosed up to 12 months after the procedure. The easiest way to think about potential steps we can take is using the different time periods we provide care to our patient. And this is actually an overview slide from a review paper from 3 years ago that demonstrates the care pathways, so preoperative, intraop, and postoperative. Why do we care whether this patient has a pre-existing neurocognitive disorder? Because it puts the patient, as we heard, if it's a major one, it puts the patient at a high risk for postoperative complication, such as postoperative delirium, which in itself is an independent predictor of morbidity and mortality. So if acute brain failure, postoperative delirium, occurs, it often sets off a cascade of negative effects. And we heard about some of them already. Postoperative complication leading to increased hospital stays, leading to reduced cognitive function, discharge to facility instead of home, and increased mortality. But the good news is that it appears to be preventable in up to 40% of cases. And that's where we anesthesiologists, I believe, can make a difference. So just to kind of go back to the definition of postoperative delirium, it's really the cardinal symptoms is inattention, and it's an acute change within the first 24 to 48 hours after surgery. And in the studies, the incidence in older patients, depending on the study, ranges from 6 to 60%. It is important to understand that this acute brain failure is thought to be a result of a complex interplay of predisposing factors and precipitating factors. So it is unlikely to just identify one single cause. I have listed here the known 5 major risk factors, so certainly age, pre-existing neurocognitive disorders, poor vision, hearing issues, severe illness, or presence of infection. And then there's a list of additional risk factors, and such as poor functional status or poor nutrition. So when we anesthesiologists assess patients preoperatively, we look for the functional reserve of different organs. And we are all used to think about the heart, right? Does the patient have coronary artery disease? We're all familiar with troponin as a cardiac biomarker. And more recently, natriuretic peptide levels are recommended in the most recent, as we heard, 2024 AHA-ACC guideline as part of cardiovascular risk assessment in certain patients. So we already have quite a focus on the heart. We also do look at the kidneys. We typically, before many surgeries, we request to have a creatine level, right? That's a renal biomarker. And there are some emerging renal biomarkers. One of them is the NGAL, and then there's another one, the KIM-1, which is the kidney injury molecule 1 biomarker. But we haven't quite, we're just getting there for the brain to even put a focus on the brain when we assess patients. There are now biomarkers for the brain emerging as potential new tools in the preoperative assessment. There's actually a long list of biomarkers that are all associated with increased risk of perioperative neurocognitive disorders. And so I have listed a few here, such as the neurofilament light chain, the phosphorylated tau species, and the amyloid beta. This brings me to the first FDA-approved blood test for a brain biomarker. It is the blood test for amyloid beta. This test quantifies the ratio between amyloid beta 42 and amyloid beta 40 to detect cerebral amyloid in adults with cognitive impairment. And it is now used as a non-invasive screening tool for Alzheimer's disease. It may facilitate earlier diagnosis and then earlier treatment. However, this is the only blood-based brain biomarker that is FDA approved at this point. There is no biomarker, to state it the other way, that is approved so far to assess the risk for perioperative neurocognitive disorders. However, there are a few very promising ones. So the neurofilament light chain and the phosphorylated tau species have the highest predictive accuracy in the studies so far. Inflammatory markers, and you're familiar with some of them, like interleukin-6 and CRP, and the S100 beta may provide additional risk stratification. But as I said, to this point, these biomarkers are not yet incorporated into routine clinical risk stratification. I still want to show you this recent individual data meta-analysis that highlights the importance of two things, in my opinion. You don't even have to read all of this because you can't. But what I want to show is that will remain complex, but we will be looking at both clinical variables, right, such as age, preoperative cognitive impairment, higher ASA status, on one hand, and in addition, we'll look at laboratory assessment, for example, the CRP, and new biomarkers coming down the line. So I expect that the combination of both clinical risk assessment combined with laboratory workup, including brain biomarkers, will be the way that we will be assessing the brain preoperatively. So what can we do? Preoperatively, as anesthesiologists, we can screen pre-existing neurocognitive disorders. We can identify the risk factors. We definitely, as been shown in studies, educate patients and get their family involved. That is very important for the outcome. We can rely on our geriatric colleagues. Many of us have access to them. They help us to assess the patient. We need to optimize hearing and vision, and we have heard about prehabilitation. We'll hear more about cognitive prehabilitation from our next speaker. What can be done intra-op? There are certain medication groups that we should avoid. Medication with central anticholinergic effect have been implicated in the development of postoperative delirium, as well as long-acting benzodiazepines. In the most recent advisory, antipsychotics such as haloperidol and steroids do no longer require routine avoidance for this purpose. What else can we do intra-op? So here's a summary that's based on the most recent 2025 ASA practice advisory. There is no clear superiority with using either a neuroaxial technique or general anesthesia at this point. There's also no superiority with what medications of what anesthetic you're using to maintain general anesthetic, whether that's an inhaled anesthetic or total intravenous anesthesia. And if you go for inhaled anesthetics, there's no evidence that any particular volatile agent is associated with a higher or lower risk of postoperative delirium. In the new guidelines, practice advisory guidelines, we are asked to consider dexmedetomidine for inpatient procedures, however, also to weigh the increased risk of hypotension and bradycardia. This is based on 63 clinical trials, but the dosing and timing still remains unclear. The depth of anesthesia is a modifiable target, so we definitely need to avoid overdose, use age-adjusted MAC fraction, and then the EEG-based techniques are not proven benefit yet, at least in the US. Let me state that this way, because when we look, and I will show you, we look at the European guidelines of the European Society of Anesthesiologists, they have upgraded the recommendation for EEG. They recommend that anesthesiologists get a more in-depth training to interpret the EEG monitoring, may it be BIS or the PSI, but also learn to understand and interpret the raw EEG data. However, that's not included in the 2025 ASA Practice Advisory. And then we should avoid relative hypotension. What do we need or can we do postoperatively? Early mobilization remains a goal. Early removal of any catheters, reestablishing bowel and bladder function, definitely regulate the sleep-wake cycle, make sure that pain is controlled adequately, and continue to avoid anticholinergic medications. And very important, get the family back involved. That's why it's important to have them part of the pre-op conversation, so to get them ready for being involved postoperatively. That is creating better outcome. So here a summary of the recommended intervention, again, divided into the time periods that we take care of the patients preoperatively, intraop, and postoperatively. In summary, we do need to focus on the brain health in the same manner that we assess other organ systems. Older patients are at significant risk for postoperative delirium and other perioperative neurocognitive disorders. So we need to assess the brain function at baseline. Input from geriatricians can be especially helpful. And then I shared some of the beneficial strategies for pre-op, intra, and postoperative care. Advancement in the field of biomarkers will enable the integration of the clinical assessment with the lab risk assessment in the near future. I leave you with this website. It's from the ASA Brain Health Initiative. Resources, they were established more than a decade ago, but the tools and resources that are available to us providers here are updated on a regular basis. So it is I find it a very useful website to go to. And we will have time for Q&As at the end, and I will hand over to our next speaker, Dr. Humaydan. Thank you.
Okay. All right. Well, thank you, everyone, for coming to hear our lecture today. My name is Michelle Humaydan. I'm at Ohio State. I wear a couple of different hats there. I'm a clinical neuroanesthesiologist, but I also study ways to prevent postoperative delirium and increase cognitive reserve. And I also am helping our system navigate through this new CMS measure, and it's brought a lot of great resources to the fight to take care of our geriatric patients better than we've done before. So I have those different lenses that have helped me prepare this lecture for you today. Okay, so to remind you, there's a lot of different things that we can think about doing throughout the different phases of care. I am going to focus on these two specific pieces of it, specifically risk assessment and the prehabilitation program from a cognitive standpoint. So as you've heard very clearly, there is a distinct relationship between pre-existing cognitive impairment and risk of postoperative delirium, and then the other complications that are coupled with that. This is a recent study that looked at those relationships, but there's a lot of other work in this area. There's meta-analyses and work that's been built on the work of Deb Culley that shows us that anywhere between 1 in 4 to 1 in 5 of our patients showing up to the operating room have some degree of cognitive impairment at baseline. And when they have that, the risk of having all of these complications and even mortality risk goes up. So the brief discussion topics I'm going to focus on today are a quick how-to on different aspects of perioperative screening for the cognitive status of our patients, and then some of the core elements of cognitive prehabilitation that you can think about incorporating into your practice. So again, same patient that you've heard, and she's 79. She's presenting for her surgery. And having read this, knowing that she's slowed down, she's worried about her independence, by a show of hands, how many people would screen this patient for a cognitive deficit at baseline? Like, that's part of your regular practice. Not a ton, right? And you're in good company, okay? Because this survey that went out to ASA members several years ago showed that in about 10% of cases or less, we're doing consistently these frailty screens and cognition screens that we need to be doing. So this is clearly an area that we need to work on, and some of the things that were identified to be helpful to help us improve this were things like development of practice guidelines about geriatric care specifically, and expansion of web-based resources. So there are no shortage of things out there now to help guide you in your practice. The ASA Brain Health Initiative is an excellent resource. The APSF is developing brain health resources as well. And as you've heard, these guidelines that have come out, several in the last 5 to 6 years, and a few really recent ones just this year from the Europeans and from the ASA. The consistent theme across a lot of this content and the most recent guidelines is we should be screening for cognition in everyone that has a risk for cognitive impairment, or based on their age, being 60, 65 and older, and that we should use this to help guide our conversations with the patients, help them understand what their real risk is, and to help us plan as a perioperative care team for how to take care of them. So I'm going to focus on a few of the things that you can use, resources to help you pick a cognitive screen. This is one of the kind of more older guidelines now, even though it's not that old, from Berger and colleagues. And they have a really great table in there that highlights about 4 or 5 different cognitive screens that you'll see routinely used in the literature and in clinical practice. So it gives you a breakdown of the advantages and disadvantages, and importantly, the time to administer, because that's a factor that comes up, a lot, is how do we integrate this practically into a busy preoperative evaluation or a preoperative clinic setting. The mini cog is probably the one you'll see used the most, so we'll focus on that one here in a few more slides. Another wonderful resource came out of the Spocky organization. They have this rapid in-person cognitive screening manuscript that has a really great breakdown of some additional tests that you can consider, and the pros and cons and other factors that you should take into consideration as you're trying to work a cognitive screen into your practice. Again, the mini cog is highlighted, some of the similar ones from the Berger review, but also some other options as well. The key thing when you're thinking about a cognitive screen is you want to pick something that's been used in preoperative settings specifically, not just in maybe community primary care settings. And you also want to take into account the considerations for the test in your patient population. So things that rely heavily on vocabulary and those types of things might not be the best for patients that have different language or cultural or educational level that could affect their ability to perform on that test. You also want to ideally co-assess some of the activities of daily living, or just how they're able to function at home that complements well with a cognitive screen. And then a key aspect of screening is to make sure that you're documenting this information. It needs to go into the EMR and also be communicated with the care team. This is going to help with goals of care discussion, a real risk assessment for the patient, and then also help the team know that they should be considering implementing delirium prevention bundles like the HELP Elder Life program. So us and our surgeon colleagues, this is something we can all agree on. As you've heard, they really have done a wonderful job with that geriatric surgical verification program and outlining very nicely things to consider to help improve our care. But we're all aligned that this is something we should be doing. It helps us have a real conversation with the patient about their risk and helps set the team up to do things focused on lowering their risk of delirium after surgery. So if you haven't looked at this resource before, it has a great step-by-step on the mini cog. The mini cog is a 2-piece test. It has a 3-word recall component and then also a clock drawing component. And you can pull out the clock drawing piece as a test all by itself as well. But this doesn't take very long to complete. And to give you an idea of how the clock drawing piece of it might look, you have a normal clock there on the left, and then some examples of an abnormal clock. So as part of the assessment, you give the patient very specific instructions about what you want them to do, and then you grade their ability to draw the clock with the instructions that you've provided. So if you're thinking to yourself, I've never done this before, I don't know how to incorporate this, there is a wonderful resource for you that is worth your time 100%. This is a collection of webinars through the Perioperative Diagnostic Excellence for the Older Adult educational platform within the ASA Brain Health Initiative. Webinar number 1 by Gina Blitz focuses on practical tips for cognitive screening. And there is an excellent piece in there about how to think about this for your patients and how to not be intimidated with starting to do this. So if you're like me, you're thinking, this is another thing that I have to do. I'm intimidated. I've never done it. But you can use this opportunity to emphasize to the patient that you're just taking a vital sign of their baseline cognition, just like you would take their blood pressure or their weight. Okay, it's just a starting point so that we all know where we're at. And that by understanding where they're at, we can better plan for their surgery and their recovery. It's important to emphasize that screening is not diagnostic. A lot of patients are concerned that we're going to cancel their surgery or there's going to be some, problem with them getting what they need, and that's not the goal. The goal is to have a better assessment of what we can do to prepare them for surgery. And practice. Don't be nervous. Watching the webinar will give you, I think, the confidence to approach trying to do this. So even if we miss the patient in the preoperative clinic setting, it's never too late to screen. You can do something quickly in the preoperative holding area. And again, the goal at that point, is to really kind of set the team up for the intraoperative and postoperative risk mitigation. So don't, starting there is a great place, and then working toward a more preemptive screen is not wrong. So don't feel like you can't do this just because you can't get it integrated into your clinic right away. So let's move on to the cognitive prehab piece here. Traditional prehab, as you have heard, focuses on 3 main things. There's a physical activity piece, there's a nutrition piece, and then there's the psychological well-being piece, which focuses on anxiety reduction techniques, helping the patient prepare to deal with the stress of surgery from an emotional behavioral standpoint. There are some resources that haven't been mentioned yet that I do want to point you to. If you go to the CDC website, it's still there right now, but you can find some information about just general aging wellness, and also some specific tips that you can give to your patient about emotional well-being. I'm not going to focus on that piece, even though that's the traditional prehab. I'm actually going to focus on the piece that I think is really interesting and important as well, and is much less emphasized, which is how can we actually build up the patient's reserve? If they are at a place where they're below, if their baseline is showing some impairment, what can we do to build them up? And even if they aren't showing impairment, what can we do to make them tolerate the stress of surgery even better from a cognitive standpoint? So a couple of resources here that I want to share about just, kind of brain health, or, what to do to tell our patients practically that they can prepare for the surgery from a mind standpoint, is you can encourage them to stimulate their mind at home. So things like reading, engaging with, email, having social engagements with their friends, their family, community groups that they're part of, anything to keep their mind active. It won't hurt, and it might be helpful. And then other aspects of general well-being, like moving, getting your sleep, using your cognitive aids, those are things that we should be routinely encouraging in our patients. And as I mentioned, the APSF has a kind of an evolving and developing brain health repository of information that you should also not hesitate to look at as well. So we're going to zone in on the stimulating the mind piece, because that's my area of research, and I want to tell you about some work that I've already done and some really promising and interesting work that's on the horizon. So I was the leader of the neurobics trial, which enrolled patients from 2015 to 2019 at Ohio State. It was a single center trial, and we had 268 patients that we randomized to either go home and just do what they normally do, or participate in a tablet-based brain exercise program. We had an aggressive expectation of them of an hour a day of brain gaming that they could break up however they chose, but we wanted them to try to get at least 10 hours of brain games before surgery. So this was pragmatic. We didn't really check in on them. We provided them the tablet, didn't require Wi-Fi to work, which is great. So it didn't limit us in who we could kind of access for the study. But really, this was just, what are the patients capable of doing on their own, and then coming back for the day of surgery and us finding out how much that they gained. What they actually did was a median of 4.6 hours, but it was a wide range. We had around 1 to 2 hours all the way up to 9 hours in our interquartile ranges. But it turns out that might be enough, okay? So in our control group, we had a delirium rate of 23%. In our intention to treat all comers analysis, we had a delirium rate of 14%. But 2 of those patients did not play any brain games at all. We had 4 patients in the entire intervention group that played no brain games. 2 had delirium and 2 didn't. So if you take out those 2 that didn't have any brain gaming exposure at all, the delirium rate was actually 13%. So this is just one trial, but I think very encouraging that there is an opportunity to continue studying this, and there might be some benefit to our patients. Another thing I want to point out is about the time. So when the patients played less than 5 hours, if we just pulled those people out, their delirium rate was 18%. When we looked at the group that played 5 to 10, the delirium rate went down to about 10%. But even in the patients, of which there were several that played more than 10 hours, the delirium rate was still right around that 9 or 10%. So I think this is really interesting because we want to kind of hit that sweet spot where we have good compliance and we're not overburdening the patients, okay? A more recent trial that's come out, because I haven't repeated this yet, I've been kind of waiting to see what else other people did. A recent trial that was very similar has also had great encouraging results. They were doing this in cardiac patients. The neurobics trial was in non-cardiac surgery, and they had a median play of 6 hours. They also asked for 10. This was actually done in-house, so the patients were in the hospital for their prehabilitation period. This was done in China. That's routine before cardiac surgery to get admitted about a week in advance. They still didn't get the 10 hours, but look at the groups and how their delirium rate was. The control group, the routine, their delirium rate was about 43%, pretty standard for cardiac surgery. It gets on the higher end, and down to 27% in that intervention group. So I think this is really encouraging that we're kind of on the right path here. There are some studies that I'm anticipating very eagerly the results of. This in-course study is looking at pen and paper-based assessments, so not the computer. They're doing like a Where's Waldo search feature and all kinds of different cognitive tasks that the patients will complete on paper. They're still asking for a pretty aggressive regimen, though, 40 minutes, about 6 days a week for the 2 to 3 weeks before surgery. So what's important, I think, is that the brain is challenged, that it's not something that's passive. They have to be actively challenged, and it has to really probably span several different cognitive domains, particularly attention, speed, flexibility, okay? And I also heard yesterday that this COPE-IOS trial that I've been watching for years just has a few more patients to enroll, and then they will be working on their analysis and publication. But this is showing their pilot study that they did and then built the full trial on. And they didn't have, these wonderful outcomes based on the physical exercise piece of the study, but the cognitive exercise piece looked very promising. And so it's just a pilot. They've built the whole trial on this, but I think that this is another one to really watch for. There's also another trial that's underway right now that's looking specifically at this dose effect issue. So they have a routine care, which is basically no intervention, and then computer games for 5 hours or computer games for 10 hours. This is my current trial that hopefully this week we'll get our first 3 patients for. This is a multi-center trial in cardiac surgery patients with Beth Israel, OSU, Columbia, and Mass General. We are adding to the cognitive exercise piece from the neurobics trial some sleep hygiene before surgery and then some IV Tylenol focused opiate-sparing pain control after surgery. So this is going to take us probably the next 3 years to enroll and finish up, but this will be another wonderful opportunity for us to learn more about what's possible in our patients and the benefit. So I'll wrap up with just this slide here. Sometimes I think people can get very overwhelmed with thinking about how am I ever going to incorporate some of these things into my practice. We're on such a hustle, but there are resources to help you frame practice improvements that are available to us for free from the ASA. So just wanted to make sure that you feel a little bit empowered to take all these theories of what we should be doing and actually put them into practice. And I really do believe that a little goes a long way. And if we start somewhere, it will be of benefit and we can build on that. So that's everything that I had to say. This is the website for the scope trial if you're interested in following that. And I love the Rolling Stones. I have not missed a tour of theirs since 1989. And if you love geriatrics, it's a great place to hang out. So thank you.
So we're opening up for questions. Any questions, you could please come to the microphone.
Hi, my name is Letha Matthews. I'm from Vanderbilt, so I see some studies from there. Great talk. Thank you so much. Everything that you presented here, it's excellent, but a lot of it has to happen prior to patient showing up. I know some of it can be done the day off, and most places don't even have a good pre-op clinic, let alone have, anything more advanced than that. Mm-hmm. So I think we need to advocate to our surgical colleagues to, places where they don't have a good pre-op clinic or a high-rise clinic or whatever set up. What are we doing as a group of anesthesiologists who are specializing in this to get our surgeons on board?
They just both looked at me. Did you feel the wind as their heads turned? So that's a good, I'm familiar with our high-rise clinic. So I think, when I tried to share is that we're all coming at this from a different framework. We either have a pre-op clinic, you've got a pre-screening program, or you might be in the process of developing that. The nice thing is that I think the surgeons are on board. So to your point, the American College of Surgeons has emphasized in almost all of their quality verification programs, and I think they might be up to 15 by now, there have been elements where there's an opportunity for anesthesiology leadership because they've recognized the need for preoperative optimization, whatever that might look like, for that particular care pathway, whether it's surgical oncology, whether it's geriatrics or pediatrics, for example. So, I think we have the best opportunity day-to-day at Elbow to talk about it, especially when you have a complication, then you talk about it. And if you're lucky enough to have sort of perhaps a roundtable discussion monthly with your case cancellations or delays, there's opportunities to bring up what you don't have if you don't have something like a high rise. And I think, too, our patients can be really good advocates for us. So much like we touched on a little bit, the things you can do behind the red line in your scrubs with your cap and mask on as you're getting ready to do your pre-anesthesia evaluation the day of surgery. Our patients, I think, will be the best advocates for this, recognizing that there's something that can be done, and do they want the opportunity to get that. Oftentimes the day of surgery, that's not going to happen, but there's opportunities when surgeons are hearing us have those conversations, there's more awareness, and then there's subsequent conversations afterwards. It does take a lot of effort and advocacy.
I'll just add to that a little bit. The CMS measures that just came out in January, those are specifically for inpatients. So, the amount of resources at my own institution that has flooded into this, meeting these CMS expectations for frailty screening and, certain aspects of the care that need to happen has been significant. And so I think that kind of like push by CMS to really focus on this is critical. And from there, hopefully things will just continue to get better. I totally agree. This is a conversation with our surgical colleagues, but they're on board. I mean, they're kind of the originators of a lot of this content on how to do things. But they don't necessarily want to do it. They want us to, I think, lead, kind of doing it. So, I'm thankful for the CMS measure, and I really hope that's the launching point for a lot of places. So.
A fun history, a piece of that. If you notice the timeline, the image that I showed was from 2019, but since then, about 2019, 2020, there's conversations with both the American College of Surgeons about the time we were talking about Frailty and Brain Health Initiative, right? CMS was getting on board, recognizing that our population was rapid of aging patients, and pre-frailty was increasing rapidly, and something had to be done. So it's not coincidental that this all sort of feels like it came together at the same time. So I would say, hop on board the train. Let's see where we go.
I am John Drummond from San Diego, and my question is really a variation of the previously asked one. We at both the U and the VA have pre-op clinics where we could pretty easily implement a clock drawing test, for instance, and thank you for the review of the tests, but most of it would be pretty close to the last minute, within 48 hours. And so what to do with the information? Are there kind of best practices, advice available for what you do with this information in terms of adjusting postoperative care if you get this information with 48 hours before the operation? What are there example institutions that you can draw to our attention that show us what to do with that information?
We can both play with that. So I've been known to do a mini cog the day of. If something doesn't feel right in the course of a conversation with a patient, it's like, what do you do with that information? Yes. That is a conversation with the family, with the patient there, that something's not quite right. The surgeons it never ceases to amaze me that the surgeons are actually willing to have the conversation, even if it means cancellation once the case is open, to pause because there's an increased risk of postoperative adverse outcome, i.e. a readmission or unexpected admission. So I think there's an opportunity for a mini-cog or for some type of cognitive evaluation at any juncture with a patient encounter during their surgical journey. So I don't think we need to be limited to just doing it in a pre-op clinic, because it does inform what you or your colleagues will do in terms of an anesthetic management. It does inform our postoperative care planning in terms of if the patient's going to be just managed by the surgeon, perhaps discharged with family, and or remains in the hospital. It's very informative to document an abnormal mini-cog at baseline. When you're talking about when your hospitalist colleagues perhaps are trying to take care of the patients postoperatively, because it provides that baseline. We get baseline EKGs unnecessarily all the time. I would say we need to be doing baseline mini-cogs much more. They're much more useful.
Well, I don't mean to rain on the parade, but let me be devil's advocate. What most of us have done are adjusted our anesthetics in the elderly to what we perceive to be the optimal anesthetic for the elderly. And when we see the elderly, we try to encourage the family to be at the bedside as fast as possible, get the glasses and the hearing aids on, and get them the hell out of hospital as fast as possible. Does the mini-cog change any of that? I really am fishing for how I can further modify my care in response to this mini-cog.
I think it's a signal. I think mini-cog's just a signal of that there could be something abnormal, but it's not absolute. You would need something much more robust to detect anything more subtle.
I can speak a little about the OSU experience. It depends on when we get the information. So I run our enhanced recovery program, and I have this all like really laid out in clinical practice guidelines for our providers. Now, how often it happens is another story. But if they screen positive, the things that we offer them are really straightforward, like talk to your family. If you have major decisions that you're kind of weighing right now in your life, maybe get those taken care of before you go to surgery. Make sure that you bring all of the things that can support your engagement with your environment, your hearing aid, your glasses, and we encourage them to get their other affairs in order, like a living will, that type of stuff. That's the extent of what we do in that preoperative space. But there's very clear, I think, care pathways for delirium prevention that are highly effective. The question is, well, why aren't we doing that for everybody? We probably should be, but I think it is a struggle of resources and just can we deploy a geriatric team to every single geriatric patient? Probably not in most centers, but if we could find the ones that are high risk, we could start there. So the HELP program has been very, very effective, and that's nothing that starts before surgery. That's kind of after the OR. So I think, you can encourage them to do things to get their affairs in order before surgery, and then implement bundles after surgery is really where we're at.
I would also say because it's a signal, there might be something else to do a deeper dive. Even just a quick cursory look at a medication list sometimes is very telling. So, and putting my hat on as if I'm in the pre-op clinic, there's a lot you can do to sort of ascertain if there's something that's modifiable on the preoperative end. And or if not, it certainly warrants conversations, because they need to expect that they might be going to a sniff and not going home.
Thank you. On the subject of conversations, if I'm not hogging the microphone, can you tell me at this year's American College of Surgery meeting, will there be conversations about prehabilitation and cognitive assessment? Is this as much on the surgical radar as it is on ours?
It is. I actually just last year was invited to speak at the ACS quality meeting and gave a talk about prehab. Itai Bentoff was there, and Kimberly Rangel, I think, or no, Liz Whitlock. So people that are kind of in the cognitive space, and they invited us as anesthesiologists to come and talk about this at their meeting. So it is definitely something that they're emphasizing, and the geriatric surgical verification program is something that I think is really
glad to hear it, because I didn't think I wanted to be in the same zip code when somebody said to the surgeon, I want to defer your case because of cognitive dysfunction. I don't think that conversation would go awfully well, but if it's on their radar, it gets easier. Thank you.
It starts as sort of a frailty conversation too, because most of the literature, you see a lot of literature comes from ours, but a lot of it also comes from the surgery literature. And the American College of Surgeons really did us a favor by creating, I didn't have the slide, but there were 12 5 years ago. I'm sure there's 2 or 3 more verification programs. And it's kind of that gold star from your society that you have had you've been through all the process and made through all the approvals, that you are doing a great job taking care of your surgery patients and having good outcomes. So I think, and plus now that we're all in the sort of the Care Compare website, and we're all being benchmarked against each other beyond case mix index, and actually looking a little more granular at how we're caring for certain populations, and that's just going to increase. I think we'll see more of that. So yes.
Thank you all.
Thank you. I think one more question and we have to wrap up, I think. Our time is...
Yes, Jorge Leal from Tampa. Have you identified any effective strategies to improve on sleep hygiene or sleep health?
What we're doing for the trial that I'm running at OSU is like a cognitive behavioral therapy based intervention, where it was originally developed for patients with insomnia, but it's a modified version of that, just to encourage people good sleep hygiene, things, when to stop with your electronics at the end of the day, what time to get to bed, how much sleep to get, if you're having trouble sleeping, what to do in that situation. So it just gives people tools to hopefully improve their sleep quality before surgery. I'm not an expert on sleep hygiene for sure, but I think it's fair to say that poor sleep is common in the perioperative, window, especially post-op, but pre-op too, but just because patients are worried and they're concerned about what they're getting ready to go into. So what I know about it so far is it's kind of cognitive behavioral therapy based, where the patients can be given an app or resources, even a coach. There's all different ways to do it, but even just referring them to basic things like an app can be helpful.
Thank you so much.
Thank you all.
All right, very good. Good job, ladies.
You did good. That's amazing.